Thank you.
So thank you very much to Uni for chairing that very interesting session. And we're moving straight into the second session. And I'd like to ask Dr. Rupak Singla, who's head of the Tuberculosis and Respiratory Diseases section at the National Institute of Tuberculosis and Respiratory Diseases, to chair the session on multidrug-resistant TB, which is really continuing on the theme of antimicrobial resistance focused on one particular disease. Thank you.
A very good morning to all of you, and I also welcome the online audience. You see, all of us, we know that in 2016, the Global TB report, it mentioned that there were almost 0.5 million cases of MDR tuberculosis globally. In the last few years, we have neurodiagnostic methods which can diagnose MDR-XDR tuberculosis within few days. We also have treatment modalities using the newer drugs. We can reduce the duration of chemotherapy to, say, a few months. But issues like home care management of MDR tuberculosis cases, issues like post-treatment sequelae, the quality of life of these cases has not been discussed much. If you look at the published literature, you will be finding that hardly any literature is there which can make a dent about these management of MDR-XDR tuberculosis. I am happy that in this current session, the MSF has included all these aspects, including the shorter MDR-TB regimen, about the quality of life of these MDR-TB patients, and also they are talking about the home-based management of the MDR-TB cases. So I request first, Philipp, you all know, he'll be talking about the comparing shorter with conventional MDR-TB treatment in Uzbekistan, 2-month culture conversion rates and treatment outcomes. So I hand over the mic to you.
Thank you very much, and now you get to see me be more nervous than the other presenters. It's a pleasure to be here this morning to present on behalf of my colleagues in MSF and in the Uzbekistan Ministry of Health. I'm going to be talking today about multidrug-resistant TB, resistance to the two best first-line drugs that we use to cure TB normally in 6 months. And up until recently, that conventional care has taken more than 20 months of treatment according to international guidelines, with 8 months of daily painful injections, treatment that causes many side effects, with in some countries up to 1/3 of cured patients going deaf, not to mention 10% having a risk of psychosis, risk of kidney failure, and many other side effects. This is very difficult to take treatment. And at the end of it all, we hear the reports from WHO, 52% success rate. And more than 500,000 people are acquiring multi-drug-resistant TB every year. So it's on that background that MSF and the Uzbekistan Ministry of Health thought, can we do something different? And we actually took some evidence from this region and tried to apply it in Central Asia. For those who don't know, Uzbekistan is one of the 30 high-burden multi-drug-resistant TB countries, and it has rates of 23% of MDR-TB amongst new cases who've never had tuberculosis before, with high rates of second-line drug resistance, as shown here. And for those who are interested, CAT-G mutation is more than 90% of cases of MDR-TB. What I'm going to talk to you today is very briefly about two studies that we've conducted, looking at testing for an association between comparing the shorter MDR-TB treatment regimen with conventional care. And we're going to be looking at 2-month culture conversion status as an interim outcome to look for any differences, and also comparing the two groups at 20 to 24 months. The shorter regimen is 9 to 11 months. It was first done in Bangladesh and has reported success rates of more than 80%. And now in subgroups of MDR-TB, it's advised by WHO as policy as one of the regimens that can be used. And data from this study and from several other studies was included in a meta-analysis to inform WHO policy. But this is really the first actual direct comparison of this regimen with conventional care. So the shorter Mdr-Tb regimen was a single-arm prospective study that we set up in 3 districts in Karakalpakstan, Uzbekistan, and we started recruitment in September 2013. I've put the WHO abbreviations, but just to make sure we're all on the same page, this is 4 to 6 months of high-dose isoniazid, pyrazinamide, ethambutol, capreomycin, or if sensitivity to kanamycin was shown, then we used kanamycin, which is the injectable agent. Moxifloxacin at 400 milligrams, so standard dosing, prothionamide and clofazimine for the intensive phase. And in the continuation phase, 5 months of 5 drugs, pyrazinamide, ethambutol, moxifloxacin, prothionamide and clofazimine. So a slight difference to a modification from the Bangladesh regimen with moxifloxacin at standard dose, prothionamide throughout the whole treatment. The inclusion criteria in this single-arm study was pulmonary multidrug-resistant TB, and the exclusion criteria was a history of treatment with second-line drugs for more than 1 month, or confirmed greater resistance either to fluoroquinolones or to both injectables, kanamycin and capreomycin, or extensively drug-resistant TB. Now, we did a single-arm study, and it's after the fact of doing the study that we decided to do a comparison, so keep that in mind for the limitations. But basically, what we were able to do, because within the same program we had another 13 districts where we were using WHO guidelines with conventional care. So we've done a comparison of the patients treated with the short course regimen in the 3 districts versus patients from a retrospective database using the same inclusion-exclusion criteria who were treated with the conventional treatment of 20 plus months during the same time period in the program. And we're looking at the outcomes, as I mentioned, 2-month sputum culture conversion, which is defined as 2 negative cultures more than 30 days apart. And for final outcomes, for the conventional care group, we use WHO standard definitions at the end of treatment, which is usually between 20 to 24 months. And for the short course regimen, we used those who, we evaluated them 12 months after they'd finished treatment. So after the 9 to 11 months, 12 months means 21 to 23 months after starting treatment. So this is the baseline characteristics. And what you can see, I'll point out there's a lot of numbers here. The key points are that in the conventional care group, we had 230 patients, and in the shorter regimen, we had 102 to compare. And mostly they were equally matched. There was no statistically significant differences, but you will keep in mind that the conventional care group had a higher proportion, with 43% having low body mass index compared with the shorter course regimen, only 33%. There were no HIV co-infected patients in either group, which is consistent with this program and the area in Uzbekistan where rates of HIV are incredibly low. In terms of the baseline characteristics, slightly more, around half of patients had cavities on their chest X-ray at baseline in the conventional care group. Baseline sputum smears were similar between the 2 groups, and baseline resistance to kanamycin was also similar, about approximately a third in each group. So what we did was an analysis using univariate and then multivariate logistic regression. And what I'm going to present is the multivariate logistic regression. There's a lot of numbers here, and the key point about a multivariate logistic regression is we're trying to answer the question, when we account for the other likely confounders, how did the short course regimen compare with the conventional care? So I've highlighted on this slide, looking at the 2-month culture conversion, that actually at 2 months, after adjusting for the other key factors, there was a nearly 2-fold increased odds of having converted, having a negative culture. So this means at 2 months on this measure, the patients in the shorter course regimen are doing better overall than the conventional care arm as a group. The model that we've used is a forward stepwise model, including parameters that we decided a priori, which is age and gender, and any factor which caused more than 10% difference in the adjusted odds ratio. Secondly, when we come to the final outcomes, and I would say that this is still preliminary data because some of the patients we're waiting for their final microbiological outcomes. But we have used a conservative approach whereby if patients don't have their final outcomes, then we've excluded them from the analysis at the moment. In this comparison, adjusting for other factors including cavities on X-ray, the adjusted odds ratio, there was no significant difference between the shorter Mdr-Tb regimen arm and the conventional care arm. So as I mentioned, there are some limitations. So this is a non-randomized study, so there may be unmeasured confounders that could account for some of these results. However, we do think there's value in the fact that this was both districts within the same program, same guidelines, similar support for patients, and similar training, same models of care. So in conclusion, in this analysis, the shorter Mdr-Tb regimen showed higher culture conversion by 2 months when adjusting for other measured confounders. And there were similar final outcomes despite significantly shorter treatment. So what does that mean? It means for this subgroup of patients, actually instead of giving them nearly 2 years of treatment, we can achieve similar results at 2 years, but they only take treatment for 9 to 11 months. Can you imagine being a patient and only having to take half the treatment time? That's quite incredible, and I think this gives further strength to the WHO recommendations about use of this regimen. This is in a particular context with high background rates of second-line drug resistance, but I think this is relevant evidence to this region in Southern Asia, which also has high rates of second-line drug resistance in Mdr-Tb cases. There may be relevance in the findings to transmissibility, and certainly for programs that use culture conversion as a discharge criteria from hospitalisation, that may be a benefit to patients. Although, as MSF, I would say we are in our programs pushing for starting treatment ambulatory from day 1, which was done in this study. We also must, I think, wait for the randomized controlled trial, the STREAM study, which should have results out next year, which will answer many of the questions I'm sure you're going to ask me, and I can only answer partially today. So thank you to my colleagues, to the staff in Uzbekistan and the patients.
Thank you, Philipp. Okay, now it's open for discussion or any comment you have. Rather, I'll invite questions from you. Thank you. Yes, please. First and then second. What has happened to the mic now suddenly? They were all working. No, please. I'll prefer you use mic.
So my name is Yogesh. I'm an epidemiologist in Manipur project.
Can you speak a little louder, please?
I'm Yogesh, epidemiologist in MSF Manipur project. My question is, have you considered analysis like previous treatment in the analysis part? So, and is there any, you using moxifloxacin? So have you see any QT interval prolongations? Because it's high dose of moxifloxacin is. So, and you, by your thing, I understood that there is a conversion in the shorter regimen earlier, but have you come across any sputum reversion?
Okay, excellent question. So 3 questions in there. I'll try and answer them all. And bear in mind that since the organisers kindly asked me to present 2 studies in the time of 1, I haven't gone through everything. In terms of measured confounders, we did look at past treatment, diabetes, HIV, age, gender, particular resistance patterns to kanamycin, pyrazinamide, and probably a couple of others as well that we had measured. And those did not seem to make any difference. Of course, there are other things in there that we didn't have good data on, things like smoking, which could have had an impact, and there may be other unmeasured confounders. The third question was around, did we see any reconversion? So yes. So one of the things I didn't go through is the failure rate. So using a failure definition that includes either having to change drugs because of adverse events or to having to change because of failure of conversion or of reconversion, then what we did see was quite a high failure rate and a much lower loss to follow-up rate. So the failure rate is 20% for this regimen, which is quite high and something that we're still looking at. But in terms of reconversion, actually most of the cases were failure to convert rather than reconversion, but we did have a couple of cases of reconversion. Moxifloxacin, we haven't looked in the conventional arm. We're not able to tease out those who got Moxi up front versus Levo and whether that made a difference. The other question that we have with our results, because the success rate is lower than what's been achieved in some other cohorts, is the lower dose of moxifloxacin responsible? Is it that we use capreomycin up front? Is it that there's just higher resistance rates? And we're not able yet to tease that out.
You see, that's my question. The conventional Bangladesh regimen by Vandion, in this regimen I find moxifloxacin is normal dose, and the pyrazinamide is being used in the continuation phase also. So what was the reason for having this change compared to the conventional regimen?
Okay, thank you. So the reason we modified the regimen is we were very concerned that while we were taking evidence from Bangladesh, how would it apply in a context where we knew we had quite a lot of second-line drug resistance and we had a high CAT-G mutation rate. So the pyrazinamide resistance is between 50 to 70% depending on which year of our cohort we look at. What we decided to do was to put prothionamide throughout the whole regimen. The downside of that, of course, is risk of side effects, which may worsen your results as well with loss to follow-up. I guess the second thing is we chose not to use moxifloxacin at a high dose as recommended by WHO because at that stage there was actually no data around QT safety. We've got a separate analysis looking at QT safety from this cohort, and what we've seen at 1 month with the standard dose of moxifloxacin is a median of 18 milliseconds of prolongation, so longer than what's been reported for moxifloxacin alone. So there is still some concern that there's not much safety data. In fact, I'm not aware of any safety data of moxifloxacin at high dose combining with clofazimine and risk of QT or torsade. But we didn't see any episodes of torsade or patients having to stop because of prolonged QT.
Okay. Next question, please. Somebody at the back row. Already answered. Okay. Yes. After that. Yes, you plus, please.
I'm Alan from MSF. I think in many countries we work, there's a higher HIV prevalence. And how do we see the results of this study useful in a place with, or are we looking at it in places with a higher HIV prevalence rate?
Okay, so there is a study that is ongoing by MSF in Swaziland that is looking at this. I can't tell you the exact numbers. All I can say is that their interim results are showing similar or slightly better results. And the analysis by WHO did tease out a bit on HIV, and it shows it seems to be performing the same in HIV.
You see, I know this study is very important, and there are several hands, but at the same time, Holly is showing me some paper. You know what it shows. So I'm sorry, I'll have to wrap it up here. Thank you so much, Philip. Thank you. We can have the questions answered in the tea time, so don't be discouraged. And after this, we are going little off what the convention we are talking about, the treatment, the regimen, the drugs and all that. So now I invite Chinmay. He is currently working as monitoring and evaluation manager at MSF HIV Mdr-Tb project in Mumbai. and he is responsible for guiding the development of the project by monitoring the progress and evaluation effectiveness. And I'm saving time because the rest of the brief bio is already there in the leaflet given to you. He'll be talking about the beyond cure and treatment success, quality of life of Mdr-Tb patients in Mumbai. Chinmay, please.
Hi, good morning all. So today I'm here before you presenting our study on the health-related quality of life among drug-resistant tuberculosis patients, which was done in Mumbai. So just to give you a brief about, we all know that India has a very high burden of tuberculosis and a very high burden of drug-resistant tuberculosis also. And Mumbai, which is, you can see here, is on the western part of this country, is a megapolis economic hub. But it also has a very high burden of tuberculosis along with very severe drug-resistant strains in the community there. So now we had already seen, Philipp mentioned before me, that the treatment for drug-resistant tuberculosis, the 20-month-old with injectables, a lot of side effects. So one of the questions is, how did it affect the quality of life? So before that, let's actually see what is health-related quality of life. So health-related quality of life, it's a patient reported outcome measure. It's the perceived illness of the patient. How does the patient actually perceive the illness that he has? It's from the disease that a doctor sees in the clinic. And it includes how the illness has affected the physical, psychological, emotional, social, and the role functioning of this patient. What exactly are the effects of the illness, how he perceives the effect of the illness on all these different factors. And why is it important to study the quality of life? Well, as a patient, their functional capacity, well-being, and the experience of their illness, it's much more important to the patient than just getting a bacteriological cure. So with this background, I just have to say that, to put it in very short term, very short, patients want to live and not just merely survive, and that's what quality of life is all about. So with this background, what we aimed was to assess the quality of life among drug-resistant tuberculosis patients. What were the factors associated with it? And we also want to explore the patient's perspectives about the quality of life. The methods that we used a mixed method study. Unfortunately, today I won't be presenting the quantitative part in detail. So we used the cross-sectional interviews for quantitative, and we did in-depth interviews for qualitative. We conducted the study in two different settings in Mumbai. One is MSF private clinic, another is Jupiter Hospital, which is a multi-specialty hospital in Mumbai. Both these settings have a multidisciplinary teams of doctors, nurses, psychologists, counselors, social workers, and psychiatrists who are on board, and all the patients are provided individualized tailored treatment with a very patient-centered treatment modules are used. So all the participants in this study are, well, drug-resistant TB patients, and they are more than 18 years of age. For in-depth interviews, what we have done is we have selected a subset of patients who actually represent, like, to get the broadest, the highest data that we can actually get from it. And for data collection, for quantitative, we use a WHO QL-BREF, that's the World Health Organization's Quality of Life Brief Questionnaire. It has 26 questions with 4 different domains. And for in-depth interviews, we used an interview guide. In the patient characteristics, we enrolled 95 patients in total, 12 of whom were enrolled for the qualitative phase. And if we look at the bottom, the TB resistance pattern, half of our patients are Mdr-Tb, which is one of the worst resistance pattern that you can have. A brief about the quantitative part of this. So what we see here is the minimum score for WHO QL-BREF can be 0, range up to 100, which is the maximum score. And these are the 4 domains that we have. And if we look here in brief, the physical and the psychological domains are the ones which were most affected. One interesting thing about quantitative that I would like to mention is that having to quit your job because of tuberculosis, if a patient actually had to quit their job because of taking TB treatment or because of their disease, it affected a lot quantitatively, a significant association with the social relations. It really affected that domain very badly. Now, going into the quantitative or the brief framework of this study, so we have 4 domains which you can see are that we have focused, which affect the quality of life. The physical domain, I'm not going to concentrate today due to lack of time. Let's go to the second one here, which is the psychological domain. So, in the psychological domain, the most effect that we see that yes, we had patients who suffered from a lot of anxiety, a lot of depression. Also, what we had seen was that TB affected the self-image, the side effects, and all the other things. It affected the way the patients perceived about themselves, and all of this in turn led that the uncertainty with the treatment about the disease, it led that they gave up, they had no hopes from their self, from their career or from their children. The only thing that they wanted, the only hope which they had was that I want to get better and I should never get this disease again. One of our patients, she said that I have asked my husband to remarry and not to expect anything from me. That was the situation they reached. And there was a different aspect also to this part where one patient said that yes, TB did slow down my life to a certain extent, but it also gave me time to think about what's important for me. He says that earlier it was more of quantity, but now it's more of quality of my life. The next part is the social and the role functioning, which we had seen was affecting. And one of the main things was the fear of stigmatization and the treatment side effects, which led to a self-imposed psychological and social isolation of the patients from all the other, and this affected even their psychological domain at the end of the day. One of a 23-year-old female, a young girl, she said that I have failed as a daughter and a sister. However, we have seen that if a patient was able to assume the role of a supporter, that if the patient could actually go and support someone, it helped them cope with their own illness. A 52-year-old female, she said that helping others with their problems helped me. I get courage from that. The next part that I would like to focus on are the environmental factors, which included knowledge, finance, and health system. So in this, I would like to focus first on the health system part of this. And health system factor, the support that the patients received from the health system, from the doctors that they say every day, from the nurses, was seen to be very important factor which affected our patients' quality of life. One of our patients, 55-year-old male, he said, doctors would not even touch me or talk directly with me at times. I was made to sit far away from the doctor's desk. I felt untouchable. When I came here, the doctor kept his hand on my shoulder and assured me that you would get better, and I felt half cured. So just simple reassurance, humane treatment at the health facilities for the patient can actually go a long way in helping the patients complete this very arduous treatment of Mdr-Tb. Other environmental factor I would like to focus is the directly observed therapy. So going every day to take their pills was seen to be something that interfered with their daily life and especially work, and this was a major stressor for all of the participants. The other factor is pill burden. Philipp said how long the treatment is, injections. Just to give you an idea, Mdr-Tb patient takes about 14,500 pills to get his treatment cured. And I cannot put it better than one of my participants, what is the effect of pill burden on their quality of life. She said, a 29-year-old female, my entire schedule revolves around medicine timings. I cannot do anything for myself or anyone else. It's like my injections, my pills, then food, then I sleep. And on waking up again, it's injections and pills and food. That's all that is left in my life now. The last and very important part I'd like to focus and spend some time on the support component. So the support from family, from close friends, help patients in overcoming the negativity or the apprehension that they had about the treatment, and this helped them to take the treatment regularly and still continue on medicines. And the other part was the support at workplace. As I mentioned even earlier, with the quantitative results, whenever the patients could actually continue their job, they got support from the workplace, from their boss or from their colleagues to complete their treatment. This gave a much higher motivation to them and purpose to their life to complete this treatment. Psychological support in form of counseling was also mentioned. Some patients also needed psychiatric care, and it was seen to be something that that helped patients. So what do these results actually mean? So all the quantitative, qualitative part. So yes, the quality of life scores were reduced. Yes, it was lower than what you would expect in normal people, and but what was surprising even for us was that the quality of life scores were not actually as low as what had been reported in the literature earlier. And the quality part really helped us to get a hang on why the scores could have been better. So I would like to say that Mdr-Tb patients who receive good standards of comprehensive patient-centered care, who are empowered and knowledgeable about their disease, and who receive support from family, workplace, and the health systems can have a reasonable quality of life despite the grave challenges imposed upon them by their disease and treatment. I would like to acknowledge all my participants, all my colleagues, and everyone who has helped me with this study. Thank you.
Thank you, Chinmay, for focusing on such an important part of the management of the Mdr-Tb cases. Usually it is missed in the hospitals, in the national programs, and elsewhere. So we have time for taking one or two quick questions. Yes.
More of a comment than a question. Would like to share our experience. I'm from basically.
Please,
from
if
Kerala.
I can interrupt you, we are here to ask questions.
Yeah. There's something called treatment support groups, which we have experimented in Pathanamthitta district of Kerala. With the local self-government, we provide for most of the things that a TB patient wants in the course of treatment. And with that treatment support group, it's a formalized system whereby the local self-governments, civil society, everybody is engaged at the panchayat level. Yeah. With that, we have been able to reduce the initial loss to follow-up rates to zero, loss to follow-up rates to zero. Okay, the paper has been published in 2015. So if we can scale it up to a national level, probably be helpful.
Thank you so much. And I again emphasize, please, if you have questions, you can ask, because we have limited time. Yes.
I am Dr. Dhyan. My question is, sir, as you mentioned, the support, family support and the social support. Was there any study which shows, was there any bias in the support between a male and a female patient, which is a common problem in our society? Is there in data which shows that this gender got this much support? Thank you.
That's a wonderful point, actually. And we have not studied this, and I am actually not even aware of a literature which distinguishes between the support that the males and the females receive. So thank you. We'll keep this in mind.
So I think you can take it in your next project. But this is a very important part about this, this study. Yeah, last question, please.
Hi, my name is Yogish. My interest is, you consider even XDR-TB patients. So have you noticed any difference in the quality of life among different resistance groups, like MDR, pre-XDR, and XDR? So that's my question.
Yes, we have done that analysis, and the answer is no. There is no difference actually with the resistance pattern. The resistance pattern was not seen to affect the quality of life in any of the 4 domains which we have seen. So as I said, it's something more than, it's like a patient perceived thing, and we do not, the quantitative or the qualitative data do not show that the resistance pattern make a difference.
Okay, thank you, Chinmay. Thank you very much on focusing for this very important point in the management. Thank you. And the last presentation of this session is from Himanshu. Himanshu is a physician and global health professional, and he has interest in the quantitative research. And I'll request him to share his observations on the very important subject, that is MSF home-based multidrug-resistant tuberculosis care model in Manipur. Yes, okay, much.
Very good morning to one and all. I'm Himanshu from the India OCA mission, and today I am here to share some preliminary findings from our MSF home-based Mdr-Tb care model, which has been implemented in Manipur. Well, as we're all aware that multi-drug-resistant tuberculosis burden has been hampering the progress of TB control all over the world. And in 2015, India reported a burden of 0.062 million Mdr-Tb cases. Poor treatment outcome has been one of the major public health challenge in control of Mdr-Tb control treatment. And hence WHO has suggested a 5-point priority action, of which provision of access to effective treatment is foremost. So with this in mind, we got to, we could go back to some of, I'm sorry, there have been some shuffles in this slide, with MDR treatment success rates that were, I'm sorry about this. The slides are quite old than what I presented. Anyway, I would make it up. Well, let us just look into some of the global success rates of Mdr-Tb treatment, and we see that the global pool data shows a success rate of 54%, and some coming from higher income countries report up to 93% of successes, while the success rates from lower income countries range something from 11% to that of 67%. And studies in India report something between 44 to 67%. However, the WHO has set a target between 75 and 90%. So with this in background, MSF has been working in an eastern state of India, which is experiencing low intensity conflict since 2004, and that is Manipur. And in Manipur, we are present in 3 clinics or 3 areas, that's Lamka, Chapikarong, and More, where we provide home-based MDR treatment care. And the success rates from such settings of conflict and lower social resources are quite scant and scarce in literature. While the Manipur TB prevalence is about 2.4%, the social and behavioral risk factors for Mdr-Tb are quite prevalent. And hence, to address this, MSF implements a home-based care model for Mdr-Tb treatment. So to understand this home-based care model treatment, we have the patients with Mdr-Tb are treated in 2 phases, in the clinic as well as in the patient's home. In the clinic, the patient generally receives diagnosis, screening, diagnosis and treatment, and the initial counseling. And at home, patient receives drugs in the form of daily observed treatment, where the patient is visited 6 days a week, and there is modification of the patient's home for a better environment and infection control. All patients do receive nutritional support and some screening for adverse events as well as comorbidities, and the patient does receive counseling at home, and the patient's family do get some education about supporting Mdr-Tb patients. MSF also takes to some community engagement and community education for Mdr-Tb treatment as well. So with this model, we expect that there is increased treatment adherence, and the environment, the nutritional, behavioral, social determinants are addressed, and there is no out-of-pocket expenditure for TB care and treatment. And hence, we aim to approximate our success proportions to that of the World Health Organization. So with this background, we tested the objective to test the treatment outcome and patterns and the success rate of this model in Manipur. So Mdr-Tb patients who were on conventional WHO regime who completed treatment between 2009 June and February 2015 formed the sample of our study. And we considered variables in 3 different groups that were being demographic, clinical, and outcome variables. Among the clinical variables, we considered the previous TB treatment history, the duration of current treatment, sputum and conversion time, and outcome were categorized as successful treatment, loss to follow-up, or death. So we describe variables for the central tendencies and then analyze the relationship between the demographic variables and the outcome and the clinical variables and the outcome. We use chi-square tests and logistic regression for statistical analysis, and this study was cleared by MSF Ethics Review Board as well as a local ethical committee in Imphal, in the capital of Manipur. So as of February 2015, we had 1,662 patients in the MSF-TB cohort, of which 118 had any kind of drug resistance. Of them, 43 had confirmed Mdr-Tb, and 6 of them, that forming 14%, were HIV positive. And among the 43, 65% were male, and there were 14.45 years dispersion around the mean age of 37. And majority of them, that's being around 69%, had a history of treatment failure, while only 27% came with a relapse of tuberculosis. So the duration of treatment was 17.3 months, and sputum conversion time expectedly preceded that of culture's conversion time. So this was our outcome of the treatment cohort, wherein 72% of our patients with a reasonably wide confidence interval had a successful outcome, as against 18.6 were lost to follow-up, and 4 patients amounting to 9.3% died during the treatment. And none of the demographic variables of the patients had any relationship with the outcome, neither did the clinical variables, but for the TB treatment, where there was a weak evidence of previous TB treatment to be having any relationship with the outcome. So the relationship was that patients with the relapse of tuberculosis had a higher chances of being a treatment failure than those who are coming with a previous history of treatment failure. Although at this point in time, the evidence is weak. So what does this all amount to? It would say that our MSF-TB cohort reports a success of proportion of 72%, and this is higher than the reported Indian studies thus far, and also higher than the pooled global analysis, which is about 58%, and lower than that of the ambulatory care model in Kenya, which is not a conflict setting and not comparable to our setting, and also lower than most of the high cohorts in high-income countries, which is quite expected. So this higher success rate we attribute to the increased treatment adherence, a favorable environment which is facilitated by MSF, and the nutritional support provided by our model. So home-based care models may have higher success rates than the hospital-based models and ambulatory models in conflict settings, and also settings where their social resources are poor. But nevertheless, these home-based care models do entail significant amount of investments in terms of human resources. Well, globally, few cohorts report unfavorable outcomes in women. They have higher odds of unfavorable outcome, also with increase in age. But in our cohort, this was not the case, that none of the demographic factors were related to the outcome. Perhaps the home-based model overcame the barriers of access for women and the elderly, and hence had similar success rates as men and the younger age. The limitation, of course, was that we have a small sample size yet, and that limited our ability to make precise estimates as evidenced by a wide confidence interval. So in conclusion, MSF Manipur TB care model demonstrates higher success proportions compared to global pooled estimates, notwithstanding conflicts and low social resources. And our treatment, importantly, our treatment success is independent of age and gender. And home-based care models thus may help to achieve the WHO target of treatment success, more so in settings of conflict. An Mdr-Tb case for relapse, TB merits close attention, and we believe that our preliminary analysis has set stage for in-depth analysis of our cohort in coming days as it grows. So thank you very much for your attention.
Thank you, Himanshu. Thank you very much. I can see many hands already raised, so I'll take one by one. Yes, Diksha.
compared this outcome as it versus resistant patterns? Was it an impact of what is the resistant pattern of those patients and then what is the outcome?
Yes,
and
we have.
Number two is, do you have the similar outcomes compared with the other regions of Manipur versus MSF clinics or the home-based?
Thank you. Well, to answer your first questions, yes, we have, but this is not, those results were not part of this scientific presentation, but I may share the results with you that the outcomes does not depend on resistant patterns. But our study is limited that we do not have a good number of Mdr-Tb patients to come to a reasonable conclusion. On the second, on your second question, we have no data on what is the outcome beyond our clinics in MSF, that's in Manipur. So the RNTCP for Mdr-Tb has not published the latest data state-wise for Mdr-Tb, but gives a national picture.
Yes.
So we have a question from online audience, Sunita Abraham from Nepal.
Okay.
Is there data available on comparison to other home-based care model within MSF?
Not yet, but may come up henceforth.
We look forward for this.
Yes.
Yes.
Thank you.
Yes. Last question, please, on the back row. Please introduce yourself.
Hi, I'm Dr. Shomadip. So my question is that you mentioned about the Kenya ambulatory model, which had shown a higher prevalence. So has that model been tried in Manipur or elsewhere in the MSF India?
Well, it has not been tried in Manipur because the setting is different. We work in a conflict zone where ambulatory model may not be very relevant because access to people is often blocked due to conflict. And the Kenya model works in an urban slum where situation is quite different. So and I don't see any plans to do that either in any of our cohorts or any of our settings.
Okay, because of lack of time, I'm sorry I will not be able to take any more questions. So we come to the end of this session. You see, we talked about, thank you, Dr. Himanshu. You see, the management of MDR-XDR is very complex. And in this session, we focused on the shorter regimen. We focused on the home care management and also the quality of life. The first two aspects are being taken care of by most of the programs, including our own program also in this country. But I'm afraid the quality of life, this part is missing from most of the programs all over the world. And I congratulate MSF that they've taken this initiative, this challenge to talk about the Mdr-Tb management, their quality of life. So with this, we come to an end of this session. I thank all the three speakers, Philipp, Chinmay, Himanshu, and I thank from my behalf to the MSF for inviting me here to chair this session. Thank you all.
Thank you. Just before the bouncers let you out the door, 3 quick things. 1, there are